sometimes some of these topics, just like acetaminophen yesterday and this topic, really help summarize just what we need to know and what's out there. I think it's confusing sometimes. The easiest thing for us to do is write for TD when they have a wound and we're done with it. It's just not that simple anymore, and we have to know what we're doing and what we're writing for. And the other issue is as well, what type of public health service are we providing to our patients, and is that really our role or not? How many of you feel it's our role to do immunizations in the emergency department, unless you're a pediatric emergency physician? Do we feel that it's our role?
Tetanus shots.
What's that?
Tetanus shots.
Tetanus shots, absolutely. But you know, how much of a surveillance and public health service do we need to provide? In the past, I would say, you know what, let the primary care docs sort this out. Let the health department sort this out. Look at the demographics of your patients and see how many of them have nowhere else to go. And I think by default, we're going to have to do these things. And that's why we have to be aware of these immunization schedules and what the changes are so we can intervene when we need to. So the first thing is we need to talk about some of the definitions here. I mean, they have made this so complicated with how these things are labeled. For children, the first vaccination we need to talk about is Big D, Big T, AP. And when they use the big letters, basically they're using a bigger dose. That's all it is. Smaller letters, just a little booster, smaller dose. The DTAP, they added the acellular pertussis portion. In 1997, they recommended removing DTP to add this. A little more expensive, but a better immunizing agent, so good for that. DTP, they wanted to get rid of it because they said with the whole cellular vaccination, it was having a lot of reactions. We'll talk about that with one of the abstracts in a little bit. I don't know if it's really been proven, but they did find something better, so no reason to go back and see if DTP is really good or not. DT, Big T, and Big T is just for those kids who can't handle the pertussis. So they had a bad reaction with pertussis before, so they need tetanus, they need diphtheria, but you can't give them pertussis. Now for adolescents and adults, the one we use all the time, Big T, little d, and basically that's our booster immunization every 10 years, whether you need it or not. And then within 5 years, or you know, if you have a tetanus-prone wound, if it's been not within 5 years, you need to have that as well. And that's probably where most of our knowledge stops. At that point, we order that and we're done and we're moving on, but we need to really consider some other things. Now the big piece of news here is Big T, little DAP. So this is the new immunization that's out there, Tdap, and very useful for us, and it's really useful for the patients as well. Newest kid on the block, added the acellular pertussis portion as well. It's fairly expensive, up to about $40 on this, but it may reduce the risk of further exposures and infections, as well as maybe even reduce the need for further immunizations. So it's a very good drug. And then tetanus immunoglobulin. You guys giving this routinely? TIG, TIG? You really should be. You really should be in certain cases. If you have a patient who has a tetanus-prone wound and they have not completed their primary immunization series of 3, or they don't know, and it's truly a tetanus-prone wound, you need to be giving this with the TD. You should be giving it. And we'll talk about some of the caveats with this as well, because if you give tetanus immunoglobulin, are you going to blunt the response actually for the TD to work? And maybe you are a little bit based on one of our abstracts. One of my pet peeves in emergency medicine is what people think a tetanus-prone wound is. And I tell you, we give tetanus shots to people who have no business getting them. We really do. If you look, and I think there's a table near the end of this chapter as well that kind of summarizes it. When you start talking about saliva, feces, soil in a wound, now we're getting there. But you know, abrasions, simple abrasions, no. A burn, yes. My biggest one is, I can't tell you how many times I've seen, when I review charts, physicians giving tetanus immunization boosters for corneal abrasions. I mean, where you got that abrasion, I tell you what, if it's soiled with feces, well then you're just looking a little too close at whatever you were looking at. But those are not tetanus-prone wounds. If you're doing that at this point, you can skip the step. It is not necessary. So we've got to really look at how we're defining them. All right, so what are the latest recommendations? The immunization series, DT, Big D, Big T, little AP, for kids 2, 4, 6, and 18 months, then again between 4 and 6 years. That's the current standard immunization series for them. And until recently, little d, big T was given, again, at 12 to 14 years and every 10 years after. Now we're recommending at 11 to 12 years they get Tdap. And if you're older and you're ready for your next immunization and you've not had a dose of Tdap, you should have it at that point. And that's an implication for the ED as well. We run into a kid that has a tetanus-prone wound, and we check the immunization history. This is what's going to be tough for us. Maybe we have to have the parents bring their immunization histories with them from now on. And if they've never had this, you need to give that instead of TD. Very important. And that goes for adults too. If the adults have never had this, and most of them probably have not, then it's very important at that point that we say maybe today isn't the day for TD, it's the day to give you your one dose of Tdap as an adult. Adults 19 to 64 had a tetanus booster every 10 years or before. Now the new recommendation is to make sure we give them that one dose of Tdap. And exceptions for this, pregnancy and adults over age 65. They should still just get TD, and they're fine with that. Abstract number 1, let's look at this. Serologic immunity to diphtheria and tetanus in the U.S. 18,000 patients between 88 and 1994. They did serologic testing with these patients. It decreased with age, so we have to really focus on the extremes of age with this. The older patients drop off their immunity. We know the primary immunization series does not give you lifetime immunity, and that's important for any of these diseases. And that includes pertussis in particular, and that includes tetanus, and that includes diphtheria also. So they looked at this, decreased with age from 90% in people aged 20 to 29 to 50% in those over 70. And so you'll hear that, that age talked about, 65 to 70. That's when we need to make sure they get at least one more booster at that point. And there's some pretty good evidence to say after 65, if you've had a booster at 65 or beyond, you probably don't need anything else at that point. Lower rates of immunity were noted in these patients, elderly, women, immigrants, and those without routine medical care for which they would have gotten an immunization series performed. Abstract number 2, Annals of Emergency Medicine, March of 2004. They looked at 1,988 patients coming to the ED for wound care. And they looked at seroprotection, 90% overall. Well, that's great, but we had a lot of young patients as well. Age 70 or older dropped down to 60%. And if you were an immigrant, not from North America or Western Europe, you only had 75% seroprotection. So we need to consider those patients. Is anyone seeing any immigrants in their emergency departments these days? More than before? Absolutely. So we have to consider immunizing them. They looked at 504 tetanus-prone wounds without primary immunization series. Not a surprise, 0% seroprotection there. And they gave them what? TD and immunoglobulin. That's what they should get. And they also recognized in this article that TD was only given 79% of the time when it was truly indicated. So we're not even good about ordering it when we know we should give that one drug. So we've got to be better about this. Abstract number 3, pretty simple. What they did was they went to primary care physicians and said, if you educate your patients and offer them screening for certain health risks, we're probably going to do better with getting patients to accept these things from you. Well, the problem was, once they reviewed the charts later, there was no documentation the physicians ever offered anything to them. And that included tetanus prophylaxis, pneumococcal vaccines, mammography, smoking cessation. They just didn't spend the time doing this. So although the primary care physicians aren't working on this, we're having to clean it up in the ED. Abstract number 4, decreasing immunity in women. The CDC reported 9,400 women between 1988 and 1994, and they looked at a subset of about 7,000 of them that they had serologic testing data on, and they could interview to make sure what their immunization history was. And they dropped down significantly. Immunity for diphtheria and for tetanus was 70% for those aged 12 to 19, dropped down to 10% at age 60. 10%. So we've got to make sure they're getting boosters. And the sharp part of the curve was between ages 30 and 39, where it dropped to 60% seroprotection for those two. So we've got to make sure we're doing this. All right, abstract number 5. CDC reported an increase in pertussis. And we know we've probably seen this, and we talked about it a little bit with the panel yesterday. A cough, more than 21 days, hey, that could be either pertussis or it could be chlamydial pneumoniae. Either one of those, you might want to just treat it if a patient has not been on either a macrolide or on a fluoroquinolone at that point. And the point was made that, well, once you have pertussis, you're not going to abate the disease at all or shorten the duration of the symptoms by treating it. No, but you do stop shedding. And the key is we want to stop exposing infants to pertussis. They have a bad time with this, and there's a significant morbidity and mortality risk with them. So if we wipe out more pertussis, less of them will get it. All right, so what they found here is 11,647 cases in 2003 and almost 20,000 in 2004. So just a year's difference, significant number of increases. 10 years old and older were 15% of the cases around 1979 and 64% of the cases in 2003. So they're getting younger. The issues here, older patients are the source to exposure to infants. And when you looked at a subset of 4,480 patients at 39 different centers with TD versus Tdap, the T and the D had the same response rates. What was very interesting, though, is when you had the acellular pertussis added to things, the Tdap, the single dose outperformed the 3-dose series. So what that's hinting is that maybe when you get a dose of Tdap, you may not need to have as much booster immunization in the future. But you've got to have the primary immunization series. You've got to have Tdap at some point. And if we don't get that, our patients are going to be at risk for pertussis. All right, abstract number 6. Cost effectiveness of pertussive vaccination in adults. They talked about one immunization. Let's just do one booster, or let's do it every 10 years. What's more cost effective? And they found out that if there are in the range of 120 cases per 100,000 or higher, both of these are cost effective. What you will do is if you do the single immunization, you'll spend less money, but you will prevent less cases. If you do the every 10 years, the decennial plan, you'll spend a lot more money, but you'll also save a lot more cases. So they're both cost effective. All right, abstract number 7, Committee on ID for the American Academy of Pediatrics. They said immunity wanes as early as age 11 to 18 for all of these. So we've got to make sure the boosters are given. And the key here for this article was making sure they got the single booster of Tdap. That was very important. If you're going to give them a meningococcal vaccine, you can give them at the same time at that point. Give them at different sites, though. You can't give them together in the same syringe, and you can't give them at the same site. It can't be an injection cocktail. You got to do it differently. They also discussed what kind of spacing you needed before your last TD or last tetanus immunization, and now you're going to go ahead and get your Tdap. And they said, well, really 5 years is reasonable because you can have a local reaction. That's all we're worried about is a local skin reaction at the injection site. Well, when they looked at the data, really there was at least one study that said 2 years is probably okay. So if they've reported a previous injection site issue, then you probably want to wait the full 5 years. But if certainly if the benefits outweigh the risks, you know, you've got some sort of local outbreak of pertussis or something else going on, you need to go ahead and just give it early and withstand the risk of a local reaction. Abstract number 8, they looked at this as well, and basically they concluded 18 months was fine. You want to get within 18 months, it's not an issue. The sooner the better if we're worried about getting the immunization series completed and this update done sooner. Abstract number 9. They said that DPT was responsible for severe reactions in the past. That was one of the concerns. Interesting abstract is when they looked at it, they found that there weren't a whole lot of these. 60 children were referred for possible reactions that they could find at UCLA. 40 had seizures, 14 had these hypotonic unresponsive episodes, 14 had fevers, persistent crying. Persistent crying, that's pretty vague, but those are some of the reactions reported. The seizure patients, 47% of them either had a personal history of seizure disorder or a family history, and a bunch of these kids had a concomitant fever with it too. So could that ever be really attributed to the vaccine? Not really. And really what Blumberg decided was he could never find anything to support that the reactions that happened were actually from the vaccination. Again, we're not going to go back in time. We've got a better vaccination now, but it was probably a little over-concern, and it probably was not related to the vaccination itself. Okay, abstract 10. Does TIG interfere with immunization? And the reality is it probably does, but you have to give that initial protection if they have a tetanus-prone wound and they've not had a full immunization series or any immunization series. They looked at 119 healthy adults, 4 months post-vaccination. Seroprotection was there in 96% of those patients when they just got TD. When they got immunoglobulin with it, it would drop down to 88%. So it did drop down a bit. Again, emphasizing in those patients why you have to remind them, make sure you finish the series. One isn't going to be enough. What is the National Childhood Vaccine Injury Act? Anyone familiar with this? Several of you are. And this is the act that's put in place to help us and the patients. If all medical liability was dealt with this way, it would be an easier world for all of us. There were so many issues with vaccinations early on when they weren't so good. They decided, let's make the manufacturers responsible a bit, let's make the providers responsible, and let's make sure the patients get specific information when they're given an immunization. Let's make sure the providers get patient identification information, the lot number, the date, all of this information written down so we can track it. And we're going to charge a little surcharge on every vaccination provided, and we're going to create a fund. And this fund will compensate these injuries from the vaccinations. It's really a products liability issue. It's not a a tort issue resulting from medical malpractice. So it was appropriately so pulled out of that realm early. And it's worked very well. The patients have to go through this process and this board and see what they determine is the appropriate outcome before they can think about filing a lawsuit. You can still file a lawsuit. You can't stop anyone from doing that. But if you accept the compensation from this and you're fine with it, there are very few lawsuits at all based on vaccination problems. So it's very helpful to us. All right, abstract 12. Are elderly patients at increased risk? The short answer is, yeah, they are. Immunity wanes significantly in the elderly. And this particular abstract, tetanus disease, primarily the elderly, is because of a lack of primary immunization and a lack of timely boosters, not a lack of response. It's a lack of giving the medicine. 70% of tetanus cases are age 50 and older. Not a bunch of tetanus cases, 48 to 91, between 82 and 88. But do you want to have one of these? If you have one of these, I mean, the fatality rate's about 20 to 30%, but if you're over age 60, 52%. Not a great thing. So we don't want people to get it. Less than 39 years of age, 98% have adequate titers. You go to age group 40 to 59, they drop down to 63%. Over age 60, 29 to 56% reported in several studies. So we have to make sure we're doing the boosters. Abstract 13, tetanus decreased by 80% in the last 25 years. So is it really a big issue to really immunize them? Well, we can look at it in a couple different ways. If we stop, will there be a resurgence of tetanus? There could be, so we want to continue this. But do we have to be so diligent that we have to continue these decennial immunizations to the end of someone's life? Probably not. And the recommendation from these abstracts would be, you know, at age 65, you get one more immunization and you're probably good to go. And abstract 14, tetanus immunity in long-term care facilities. 70% of ECF patients could not recall immunization history. They can't recall the color of their drool this morning. You guys seeing the same ones I am? Are you asking, did you have a full immunization series provided? They have no idea. But it should be upon the ECF as well as the primary care provider to decide if they have. And if not, this abstract says it's worthwhile, just go ahead and start the series. If they've not had it, just go ahead and give it to them. And what's interesting as well from this abstract is those who are more likely to have tetanus-prone wounds, like chronic wounds, don't have immunity, 21% versus 2%. So those who don't have immunity are also the ones who are going to have big bed sores and fall and have lacerations and everything else going on. So they're the ones we want to treat. All right, abstract 15. Seroconversion, single dose of TD. They looked at 150 ECF patients. If they had a previous vaccination history, yeah, I think I was immunized, I think I had all three, then the booster got them to 94%. Well, great, it's doing exactly what it should. If they were uncertain of the vaccination history, went down to 69%, and if they knew they had no previous vaccinations, it was the one dose gave them 56% immunity. So that's not so helpful. And not surprising, those who had an uncertain history, a good portion of those never had an immunization. So again, in these patients, immunize early and often and frequent and whatever else you need to do, but they need boosters and they need a primary immunization series if they haven't gotten it. I mean, usually what I'm hearing is those patients who are 80, 85 years old, most of those never got an immunization series, so they're getting probably TIG and their TD and the ED. Abstract 16, antibody protection to diphtheria in geriatric patients. Remember, diphtheria, we're not seeing much of it these days, but it shows up just like an upper respiratory infection. You get a fever with it, sore throat. You get some pseudomembranes in the back of the throat and on the tonsils. The problem is it can progress to a demyelinating disease. You don't want this to come back. This is not a benign disease. So this abstract just tells us at 16, let's not do away with the little d portion of the TD. We need to make sure we continue to immunize for this. Abstract 17, immunologic response to tetanus toxoid in geriatric patients. Low immunity levels, we know that. And it's a failure to immunize and not a failure to respond. If we do the right thing and we provide the booster when they need it, they're going to respond and they're going to get good seroprotection. They're going to be fine. And basically, abstract 18 supports the previous references and abstracts on older patients. And 19 says, in summary, immunization histories are unreliable predictors of immunity. Immunization provides immunity for most elderly patients if you give it. And so when these patients come in, we've got to make sure that we're providing it, trying to get a good history. And if we can't get a good history, assume they have not had a series, so consider tetanus immunoglobulin. And the take-home message also is to make sure that the patients get Tdap. If they're in that 11-year age group and they're ready for the next immunization, that's what they should get. If they're in that teenage age group and they never got it, they should get it at that point. And adults should get it one time. And we need to make sure that we're not as concerned about diphtheria, but we don't want it to come back. Pertussis is on the rise. We've got to make sure we're dealing with that. And so Tdap is a great plan for that. And of course, tetanus is a horrible disease, not many cases. We do not want to let it back in. We don't want to open up the door. So we've got to make sure that we're protecting our patients, particularly women, particularly the elderly, and make sure that if they've not had a primary immunization series, that they start that immunization series, and when they have a tetanus-prone wound, if they've not completed it, they get immunoglobulin. That's all I've got for you.